Bismillah ar-Rahman ar-Rahim. Today we are going to talk about a very important topic about how to differentiate between most common disease in ICU by X-ray. So I have to divide the diseases in ICU in X-ray in three categories by X-ray based on the densities or lung opacities. The first group actually it will be a ground glass appearance. And the second group it will be fine reticular opacities or densities, and the third group it will be the coarse reticular infiltrate or coarse reticular densities or opacities. We'll see here the first one here, the ground glass appearance. The ground glass appearance, if you will see the X-ray and come to you and this ground glass appearance, what is the differential diagnosis? It will be RDS versus GBS. RDS versus GBS. So your differential diagnosis or your impression, if you will see this X-ray ground glass appearance, immediately put your differential diagnosis RDS and GBS. What is the meaning of ground glass appearance? Ground glass appearance, this means the air space is atelectatic or replaced with exudate or transudate. So the ground glass appearance, so is diffuse haziness. I cannot comment about the X-ray. I cannot see anything actually. عامل زي الزجاج المصنفر. I cannot comment about the X-ray because diffuse haziness, diffuse opacities, densities. So this why? Because the ground glass appearance, the air space replaced with partially or completely atelectatic changes, or replace it with transudate or oxidate. So how can I differentiate? By history and clinical examination and the laboratory. History and examination and the laboratory, and also the natural disease or the course of the disease, natural course of the disease, the onset, course, and duration. So if you see this X-ray, this is ground glass appearance. Why ground glass appearance? Because it's diffuse haziness, diffuse opacities, all airspace at atelectatic changes, show it as atelectatic changes. So this is RDS or GBS infection. So I will take history. This history, this baby gestational age is preterm. Immediately this is RDS, always in the premature baby. This baby is full term, so this will be ground glass appearance related to the GBS infection. So by history and also by association. If you see the association, pneumonia or GBS infection commonly associated with pleural effusion. So the pleural effusion rare in the RDS, but what is common with RDS, the complication or association, it will be pneumothorax. But what common association with or complication with the GBS infection or the pneumonia, it will be pleural effusion. So ground glass appearance in the X-ray. So what is the meaning of ground glass appearance? This I cannot comment about the X-ray. It's diffuse haziness, diffuse opacities due to air space atelectasis or replace it with exudate or transudate. So the only two differential diagnosis in neonatal period, it will be RDS and GBS. How to differentiate? By history. This is baby preterm or full term, and also the course or the natural course of the disease, and also the common complication or association. The pneumothorax, it will common associated with RDS, and the pneumonia or GBS infection, it will be pleural effusion, parapneumonic effusion. The second category here, it will be fine reticular. You will see fine reticular. What is the meaning of fine reticular? It will be like strix, small strix, fine. Actually, it will be difficult to find it. Fine, this mean water. You have only two differential diagnosis, TTN or pulmonary edema or edema due to cardiac disease. Because the TTN, it will be mimic the pulmonary edema or the cardiac disease. We call it wet lung. So they call it fine reticular infiltrate, fine reticular density, fine reticular actually appearance, fine reticular appearance. So we have only two differential diagnoses, the TTN or pulmonary edema due to cardiac disorders. How to differentiate? I will take history, examination, and laboratory. Then I will check the natural history of the disease or the onset course of the disease. So if there is history of this baby having cesarean, full term, mother diabetic, mother asthmatic, I will put in my mind this is the TTN. Most probably it will be TTN. Also the cardiomegaly is more prominence in the heart disease more common with the heart disease rather than with TTN. And the most important area to differentiate, this is interlobular fissure. It will be here, interlobular fissure here, interlobular fissure. It will be fissure, actually interlobular fissure. It will be common with the TTN. This is it will help for differentiation, and also the wet lung. Actually, the TTN can start it from normal X-ray up to pleural effusion or heart failure So the main area of differentiation, the history, baby is full term, cesarean, and the mother diabetic or asthmatic, and also the cardiomegaly. There is mild cardiomegaly with the TTN. It will be common with the TTN. Pulmonary edema, the patient will be actually having cardiomegaly and pulmonary edema. If you look for the natural course of the disease in the TTN, after 48 hours, 72 hours, it will became normal. It will the resolution. It will be resolved. It will be resolved. In cardiac, the cardiomegaly, it will not resolve. So it will. Will give you clue. This is cardiac rather than the TTN. If the third category here, it will be the coarse reticular infiltrate. Coarse is mean batches. Coarse density or coarse infiltrates, it will be batches. This is common to disease meconium aspiration or pneumonia. Meconium aspiration or pneumonia. How to differentiate? History and examination, and the natural history of the disease or investigations. So by history, there is sick meconium at the birth and fetal distress and difficult labor, and all of this will give you clue. This is meconium rather than to be pneumonia. And also pneumonia, it common associated with effusion, pleural effusion, parapneumonic effusion. But the meconium aspiration common association is BPHN or pneumothorax, BPHN or pneumothorax. So how to differentiate between the three categories? By X-ray, by look for the densities, look for the obesities. If ground glass appearance, what is the meaning of ground glass appearance? So it's diffuse hissness. I cannot actually appreciate the X-ray. I cannot see anything. Why? Because the air space is atelectatic, or replace it with oxidate or transudate. Fine, it will be water. Fine, it will be pulmonary edema. It's common in the TTN and pulmonary edema or the cardiac disease. And the third one, by if there is coarse infiltrate or reticular infiltrate, this means meconium aspiration due to particles, due to material, so due to meconium or due to pneumonia, due to the infiltrate. This is how to differentiate between the categories or the common disease in ICU in the X-ray by the densities or by obesities. Based on the obesities, ground glass appearance, I cannot see anything. It's hissness, I cannot appreciate any infiltrates or fine nodular or coarse nodular. So this is ground glass. It will be RDS or GBS. RDS common in premature, and GBS it will be in the full term. And also pleural effusion, it will be common in the GBS infections, and pneumothorax common in the premature baby. And the course of the disease, the RDS, it will be progressive. Then after 48 to 70 hours, it will be regressive. In the pneumonia, it will be progressive. It will be progressive all the time. It will be progressive. Fine reticular, it will be fluid. Fine fluid. The lung field, we have to commit up lung field and lung volume and also fluid. Fine, it will be fluid. TTN and the pulmonary edema or cardiac disease. And the most striking feature, this is fluid in the fissure. It will give you clue. And also by history, the baby is full term, cesarean, and there is maternal risk factor, asthma or infant of diabetic mother. If this is coarse features, it will be only two. It will be diffuse bilateral coarse infiltrates. It will be meconium or pneumonia. How to differentiate? Take history. History, it will give you history of the sick meconium and the fetal distress. And diffusion common with pneumonia. What is normal? If you see here, this is the normal X-ray, the dark lung appearance. This is dark lung appearance. You see here, this is dark lung appearance. This is normal X-ray. You see, this is what? Light lung appearance. Light lung appearance. This is the obesities. It will be white. So this is light lung appearance. This is diseased lung. This is RDS or GBS infection. This is the diffuse ground glass appearance. Diffuse ground glass appearance. Diffuse ground glass appearance. This is mean diffuse ground glass appearance. So I cannot comment about the X-ray. I cannot comment this is fine reticular or reticulonodular or granular or coarse infiltrate or patches. I cannot comment this is fine reticular or coarse reticular or granular or whatever. So this is ground glass appearance. You could diffuse bilateral haziness. I cannot differentiate. This is called ground glass appearance. Only to disease RDS or GBS infection. GBS infection. You have to take history and check the natural course of the disease. The history, this is preterm, this is full term. The common it will be pleural effusion with pneumonia, and the pneumothorax will be with RDS. The course or the natural course of the disease, the RDS, it will be progressive, then it will come down after 48 hours, the diuretic phase, it will, the regressive course, it will be happen, but in the pneumonia, it will be progressive. It will not improve immediately, actually. It will not improve immediately. If you see here, this is the progression of the RDS. If you see just the reticulonodular pattern, then we'll go for the severe form. It will be ground glass appearance. Ground glass appearance, the airspace atelectatic or replaced. The airspace atelectatic or replaced. If you see here, this is the fine reticular or the edema or the wet lung. This is the TTN and pulmonary edema. TTN and pulmonary edema. The most striking features for the TTN, as we mentioned, can be normal X-ray up to pulmonary edema and cardiomegaly or mild cardiomegaly. If you see here, this is, you have to look in the TTN in the perihilar area, because all it will be prominent perihilar strix and bronchopulmonary vascular marking or pulmonary vascular or interstitial marking. Pulmonary interstitial marking, if you see here, pulmonary interstitial marking, also it will be more prominent. It's more than 2/3 actually. It will be more prominent. And the most important one, the fluid. You see the fluid in fissure or interlobular fluid or fluid in the fissure. It will give you clue. This is the TTN fissure, interlobular fluids, or we call it fluid interlobular fissures or fluid in the fissure. You see here between, you see in the right lung, in the fissure, there is fluid. So prominent perihilar streaking. The second, it will be increased interstitial marking or bronchopulmonary vascular marking. And the third one, and the most important, the fluid in interlobular fissure. Fissure. In the pulmonary edema, sometimes it will be mild cardiomegaly. In the pulmonary edema, it will be almost the same, like flavicotin appearance and increased pulmonary vascular marking more than 2/3, and there is cardiomegaly. But the TTN, if you will see the natural course, after 48 hours or 72 hours, it will resolve immediately. It will be, the lung, it will return to normal. But if there is pulmonary edema or cardiomegaly or cardiac disease, actually it will not resolve like the TTN within 48 hours to 72 hours. After 72 hours. The last one, it's a coarse infiltrate or reticular infiltrate. The coarse infiltrate will be two differential diagnoses: the meconium and pneumonia. The meconium, if you see the meconium, it will be actually area of hyperinflation, area of atelectasis, and also density bilateral. You call it coarse bilateral infiltrate. Diffuse coarse bilateral infiltrate. And also the most common complication, it will be PHN and also pneumothorax. If you see here the pneumonia, this infiltrate and effusion. You see infiltrate and infusion. It will be coarse bilateral infiltrate and patches. It will be patches. This is the most important, and also it will complicate with effusion, pleural effusion. It will complicate it with pleural effusion. So how to differentiate between the common disease in the NICU by the X-ray? You have to divide the X-ray in the three categories. Based on what? Based on the densities or the X-ray densities or obesities. This obesity is actually is ground glass or fine reticular or coarse reticular. So ground glass, I cannot actually comment about the X-ray. I cannot see anything. Ground glass appearance. I'm الزجاج المصنفر. So I cannot comment this is fine reticular or fine reticulogranular or nodular or coarse reticular. I cannot comment this is fine reticular or coarse reticular. So if you cannot comment about the X-ray, this is fine reticular or coarse reticular, this means ground glass appearance. The two differential diagnosis of ground glass appearance, it will be RDS and GBS infection. And GBS, how to differentiate? By history and clinical examination and investigations, and also the course or natural course of the disease. So if premature baby, it's common RDS. If full term, it will be GBS infections. If this baby complicated with pleural effusion, it's common with pneumonia. Pleural effusion is rarely with RDS. It may be complicated with pneumothorax. If the X-ray there is reticular or fine reticular infiltrates, you have to differentiate diagnose the TTN or pulmonary edema. Pulmonary edema, this is of the cardiac, it's due to cardiac. How to differentiate? History and examinations and investigation also, and by natural course of the disease. In the TTN, it will be prominent hilar. Look for the hilar area, prominent hilar area, and the interstitial infiltrates and the interlobular fissure, in fluid in the interlobular fissure. And also the natural course of this, it will resolve after 48 to 70 hours. It will be normal lung. But if there is cardiac disease or pulmonary edema, it will not be actually normal. It will not return normal within 48 hours to 72 hours. If there is coarse reticular infiltrate or densities or opacities, this coarse patches, looks like patches, only meconium and pneumonia. Meconium and pneumonia. How to differentiate? History will give you, this is history of meconium, fetal distress, and the premature rupture membrane, and all of this. It will give you clue. This is meconium. And also in the pneumonia, it as we mentioned, patches. You see patches and effusion, patches and effusion. Look for patches and effusion. As we know before, you have to comment about the lung field and volume and fluid. Lung field. Actually, the lung field is patchy, coarse, bilateral infiltrate or patchy infiltrates. This is the lung field. The lung volume in the meconium, it will be area of hyperinflation, area of atelectasis, area of hyperinflation and atelectasis. Also in the lung. Also the fluid, the pleural effusion. Pleural effusion is common with pneumonia, called parapneumonic effusion, parapneumonic empyema, parapneumonic. It's all, it will be with pneumonia, But meconium, the common complication association, BPHN can be complicated with pneumothorax, but in your mind the pneumonia, it will be effusion. At the end, I would like to pray for my colleague going for Saudi board, Jordanian board and Arab board, and my colleague in going for exam for neonatal fellowship. ومن أحياها فكأنما أحيا الناس جميعا. شكرا.